Dr. James Ekman practiced academic medicine for more than 41 years. He was medical director of the Georgia Comprehensive Sickle Cell Center, the world's first 24-hour comprehensive acute care sickle cell program. He has broad research experience, including studies of psychological and social complications from sickle cell disease, pain management and assessment, and bone marrow transplantation. He participated in a HRSA project with Georgia Children's Medical Services to improve transition in youth with hemoglobin disorders. He was on the Oversight Steering Committee for the HRSA Sickle Cell Disease Treatment Demonstration Project. He collaborated in the previous CDC RUSH and FRESH projects on sickle cell disease data collection, and he's committed to establishing a long-term national surveillance system and registry for this population. His present activities focus on public health services for individuals with genetic diseases. He's working on youth transition and improving access to and use of adult-centered primary care medical homes in various care settings with hydroxyurea use as an outcome measure. Dr. Ekman remains active in medical education and helps maintain scinfo.org, a website providing multi-level educational content. As a reminder, this session is being recorded.
Okay, thank you. Thank you for the invitation to present today. I really am excited about this. And what I'd like to do today is sort of to give you an overview of what sickle cell disease is like for our older population. Could I have the next slide, please? So I'd like to first have us understand that the demographics of sickle cell disease are changing, and in the past the disease has been primarily centered in pediatrics, and now we know that the majority of patients actually are in the adult age group. I'll learn some of the problems that occur with adults with the disease, understand how hydroxyurea may improve the quality and quantity of life in sickle cell disease, and then finally, to put this in perspective, that we really lack data and understanding of the real face of sickle cell disease in older patients because there's very little data to base our experience on. So if I could have the next slide, please. I have no conflicts of interest, and I'm not going to discuss any off-label use of drugs during this discussion. I have to state this each time for my institution. Could I have the next slide? Now, recently things have really become very exciting for sickle cell disease. This is data that I'm sure everybody has seen repeatedly, but basically it documents the impact of newborn screening on the improvement of survival of children since newborn screening has been introduced about 30 years ago, and good health care has been available for the infants and children detected with sickling disorders in the United States. And we can see studies now from Dallas, London, and now Brazil have documented the fact that if you have a health system that documents the disease at birth and individuals entered into a good healthcare system, virtually all of the patients are going to live to 18 or 21 and transition into the adult health care age group. Next slide, please. Now we just have published, or is in press, an analysis of the California and Georgia RUSH data. And this slide depicts the age of death, or the age-specific death rate for sickle cell disease based on our recent RUSH data analysis that you've already heard about. And what you can see in this slide is that up until about the age of 14 or so, the mortality rate for infants with sickle cell diseases, or children with sickle cell disease, is the same as the general population. Through the adolescent period and into adulthood, there is an increased mortality in the sickle cell disease population when compared to the general population or an African American population. The sickle cell population is shown in the dark solid line, African American in the light solid line, and the general population in the dotted line. As the patients get older, the death rate appears to normalized for the sickle cell disease population, but we must remember that this represents a very small number of patients. Next slide, please. Now, there's been a very interesting recent publication from the Jamaica experience, and Dr. Sargent has had an active sickle cell program in Jamaica for a number of years. He has the advantage of basically knowing the sickle cell population at risk in Jamaica, and they have a large registry of patients that have been followed for now over 60 years. He also has established a cohort study where he has identified a large number of individuals with sickling diseases at birth and matched them to an age sex match control population, and then followed them now for in excess of 30 years. One of his recent observations was that he looked at their experience from 1943 through 2003 and was able to identify 102 individuals who were over the age of 60. 40 of these individuals were alive, and their ages range from 60 to 87. So clearly there is a cohort of individuals with sickle disease that are living to almost normal life expectancy. His observation was that fetal hemoglobin was associated with survival. That is, increased fetal hemoglobin predicted a better survival. Patients who were followed in his cohort had fewer pain crises as they aged. They also developed progressive anemia and a progressive increase in creatinine, suggesting underlying renal disease. Next slide. Now, there's very little data on the actual characteristics of sickle cell disease in the adult population, and most of my comments are really going to be based on my experience from our Georgia Comprehensive Sickle Cell Center. And this is a unique clinic that was established in 1980. We initially set our goal to combine a pediatric and adult program that would provide medical care from birth to death for individuals in the Atlanta metropolitan area in the state of Georgia with sickle disease. In 2007, the pediatric program became separate, and our center focused uniquely on adults. We have over 4,500 individuals registered in our database, and over the years have had approximately 1,000 active patients. That is a patient that was seen in our clinic at least once every 2 years. In addition to a medical home, we provide 24-hour urgent care. We have a separate emergency clinic that the individuals can be seen 24/7. We provide comprehensive primary care, tertiary care, and as I'll show, it's a model of cost-effective disease management. We also develop the opportunity to participate in education and research based on this. Next slide. One of the unique aspects of our clinic was that we have a 24-hour emergency room that specifically focuses on individuals with sickle cell disease. Patients over the age of 18 are seen there for any problem that they present to the hospital with, except pregnancy and acute trauma. They're treated by an MD or a physician assistant in collaboration with a nurse and a clinic assistant, and we have very specific clinical guidelines that we've developed that they follow so that the patients can receive prompt and specific care. We used aggressive pain management and fluid management, and patients were treated for 8 hours, and if they improved, they went home, and if they did not improve, they were admitted. 80% of the patients were successfully treated in this setting and were able to leave. This activity really provided an opportunity for us to be really a primary care facility and take care of a large number of individuals who were both symptomatic and asymptomatic with the disease. And we had an online database that we used to manage the clinic that also provides data on the characteristics of the population. Next slide. This shows the age distribution of our patients, and this is done in 2001, and it represents approximately half of the patient population we were following. And what you can see, the yellow bar on the left are individuals with SS, the middle bar in red is SC, and the green is S beta plus thalassemia. And as has been reported in most centers, about 2/3 of the patients are SS and about 1/3 are SC in the younger populations. And you can see there are patients that are living into the 50s and over 60. And as they get into this age group, the number of SS patients and SC patients are approximately equal, probably related to a higher mortality rate in the individuals with sickle cell disease. Next slide. This shows the distribution of our active patients, and I have shown the 2001 data next to our 2016 data. And basically what you can see is that again, in the patient population, the majority of patients are young adults, with most of them being under the age of 50. But we do have a cohort of significant number of patients who are in their 50s, 60s, 70s, and we have one patient with SS disease who's 81 years of age. So that basically we have a tail of individuals who are older. Clearly, in my estimation, the mortality rate in older patients with sickle cell disease is high, and their survival is somewhat shorter than the general population, but we really have no prospective data that allows us to identify the actual median survival of patients with sickle cell disease. Next slide. Now I'm going to start moving through and talk about some of the problems that the adults face, and many of these are similar to what is seen in pediatrics, but certainly there are a number of unique things that occur. And for pain, for the adult patient, pain is certainly the major issue that they have to deal with, and I'm going to spend some time on that because I think the pain experience for the adults is very much different than it is for the pediatric population. Next slide, please. This shows an old study from the natural history study, the comprehensive study of sickle cell disease that was done in the 80s and 90s, and this is Platt's data. And what you can see here is pain rates in each of the phenotypes. And in each of the diseases, the first bar in white is individuals who have no pain episodes in the observation year. The green bar is individuals that have a few pain episodes, and as you go to the right, there's increasing numbers of pain episodes up to greater than 6 a year. And what you can see is that in SS disease, there tends to be a higher proportion of individuals with SS disease that have pain than with the other phenotypes. But I think it's important to note that all of the phenotypes have very significant numbers of pain episodes in a year, and that the distribution is slightly different, but all degrees of severity are represented. This is especially important in the adult population because the SC patients and the S beta plus thalassemia patients often are relatively asymptomatic from pain episodes when they're children. But as they become adults, they have onset of pain, and their frequencies of pain really do approach the SS patients. In addition, my observation and some preliminary studies suggest that individuals with SC and S beta plus thalassemia may actually have increased problems with chronic pain over the SS population because they have a higher rate of bone problems. So in the adult, all of the phenotypes are severe as far as I'm concerned, and there is really no significant difference in the disease severity in the various phenotypes. Next slide. The other thing that's very important is that the disease acts up in early adulthood. And I really want to spend some time on this because when I first saw this data where emergency room rates increased dramatically at age 20 through about age 50, hospitalizations increased, and as we found, mortality also increases, I really thought that what was going on here is that the patients became symptomatic. They had a lot of trouble, and those that were having the most trouble had a high mortality rate. So the older patients really were not represented in the data, and therefore the rates of ER visits and hospitalizations decreased. But in talking to my patients in their 50s and 60s and 70s, I really learned that the individuals experience this, and most of them related to me that yes, when they got to be adolescents and young adults, they had terrible time with their disease, with very frequent pain crises, a lot of complications and real severe problems with their disease. And as they got older, it quieted down, and they actually did better. And in really carefully questioning them, the reason really gives us hope that we can impact on this in the future. Most of them related to me that the reason that they felt they had done poorly was that they tried to ignore their disease. They tried to pretend that it didn't exist, and they tried to do everything that all of their peers were doing, and really caused a lot of problems for themselves. And they recognized the fact that that if you did certain things with this disease, the next day you would be sick and in the emergency room and having a pain crisis. And as they got older and smarter, they realized they had to modify their disease, their life based on their disease. They learned to live with the disease, to control the disease, and control their behavior so they didn't have problems with the disease, and things got better. So I'm very hopeful that in the future we can take this kind of observation and try and use our older patients to educate the younger ones so that going forward, hopefully, they won't have to suffer this excess morbidity in early adulthood. I'm certain that having these repeated complications also increase the mortality, and hopefully it will also improve the prognosis for the patients in terms of longevity. Next slide. Now, what I showed you were emergency room visits, and I think it's very important to realize that Dr. Smith pointed out something that I learned but really didn't appreciate when I first started taking care of individuals with sickle cell disease, and that is that the emergency room visits for sickle cell are really the tip of the iceberg, and that sickle cell patients, in addition to these acute pain episodes, have a lot of chronic pain, and they have a lot of acute pain episodes that they deal with at home, never seeking medical care. If I could have the next slide, please. This is the reference for Dr. Smith's very important landmark paper where he took a large cohort of individuals and collected pain diary information over a period of months to better characterize what their real pain experience was with sickle cell disease. Next slide. What his data showed is that pain really is almost a daily occurrence in most patients' lives, and in each of the in this bar, we have the percentage of patients, and each of the bars represents a different number of percentage where they recorded days in pain. And what you can see is that about 30% of the patients have pain virtually every single day. And if you look, about 50% of the patients have pain at least a half of the days of their life. And so sickle cell pain is not just acute pain crisis, but it also is chronic pain. And if I could see the next slide, this is shown graphically. And in the data set, the diaries, about 45% of the days the individuals would experience no pain. In an additional 20% of, just a second, I got to get this, whoops, I can't move it. I can't see the numbers. But basically, in about 25, can you move that over for me?
I think the number you're looking for is about 20% for 20%, the red
yeah.
and yellow together?
And then 12% for the yellow. So there are many days where the patient has pain but don't perceive it as pain crisis. About 12% of the time they have pain crisis but do not go to the emergency room. And only about 3.5% of the time do they have pain that they actually went to the emergency room. So what this is saying is that basically chronic pain is more frequent than pain crisis, and even if the patient has a frank pain crisis, the majority of times they'll manage that at home and not seek health care. And so our perception of the disease is not accurately assessed when we think about emergency room visits and hospitalizations for pain. Next slide. Now, the reason for this, I think, is that over the years, the sickling phenomenon really creates chronic damage to bones, muscles, and probably other structures that are painful. And some of these we can clearly see. The vertebral changes that occur in sickle cell disease are classic. They're so classic that a radiologist can make the diagnosis looking at a chest x-ray. It's really amazing to me that every patient with sickle cell disease doesn't have severe back pain because their vertebral bodies are collapsing as they go about their daily activities. Many of the patients develop bone infarctions in their long bones, and a significant number, particularly FC patients and S beta plus val patients, develop avascular necrosis of the hips and shoulders, and so they develop chronic arthritic type pain on top of their pain episodes. Leg ulcers are fairly common, and I think our visualization of some of the other soft tissue damage that can occur around the body that might lead to pain. Next slide. Now, so this really brings us to the realization that for the adult, sickle pain is very complex. Initially, it's nociceptive, it's acute, self-limited, based on probably sickling and ischemic damage. As the patients age, they develop chronic pain from the tissue and organ damage. And on top of this, many of them develop chronic pain syndrome, where there's actually remodeling of the nervous system, and so the pain perception is increased, and in fact the neurons may start firing independent of any damage, and so the pain is persistent even though the damage has been repaired. The other thing that's very important that changes this in sickle cell patients is the prognosis for survival is very good. And so In many disorders, cancer and other models of chronic pain, once a person starts having severe pain, their prognosis for survival is very limited, and so you're dealing with a very short problem of having to manage the pain. In sickle cell disease, they're going to live for many years, decades, and so your approach to this chronic pain has to be different. So you modify it, but you do it in a way that will continue to work over time. And the bottom line for this is that our opiate analgesics, which work in some of the other chronic pain settings, are really inadequate for sickle pain when it becomes a chronic problem. Next slide. Now we're starting to really understand the neuroanatomy of pain, making great progress, and there's all sorts of imaging techniques where we can look at the metabolic activity that's generated on the left, the right side, showing that certain areas of the brain light up with anticipation. Once the pain is perceived, other areas light up, and with relief, the metabolic activity in the brain goes back to normal. And so we're really developing tools that allow us to better understand the sources of both acute and chronic pain. I'll have to add, however, that this really has not translated into any real improvements in our ability to control chronic pain, and that still remains an area that is very problematic for the adult and needs much more research. Next slide. Now, the second thing that occurs related to the chronic pain experience for the sickle cell patient is that they, there is a social and cultural impact of the pain in sickle cell disease that we have to understand. And pain in sickle cell is a unique lifelong experience, and one of the things that happens based on this experience is that they're constantly exposed to opiates. And opiates are wonderful acute pain modifying agents, but they have very limited utility in individuals with chronic pain. Tolerance develops very quickly, so that the same dose of opiate that was effective a few weeks ago is no longer effective if it's used repeatedly. When a medication is used daily for more than a week or so, you develop physical dependency on the medication, and the nervous system will start firing spontaneously when you remove the opiate, causing an abstinence syndrome that can mimic a pain crisis. And with higher long-term use of opiates, the opiate itself is now understood to induce pain. It increases the perception of pain and actually can cause spontaneous firing of the nerves and generate pain without any noxious stimulation. Now, this has great social impact. Tolerance, and when a person goes to the emergency room, means that they're going to need a much higher dose of medication than the emergency room physician is used to dealing with. And there immediately is a reluctance for the healthcare provider to provide the amount of medication that the individual needs. And this really sets up dynamics so that there's an antagonism between the healthcare professionals and the patients. The physical dependency can be a real problem, in that the patient has symptoms related to drug withdrawal that either precipitate a crisis or are perceived as a crisis, and you get into serial a cycle of repeated pain occurring every 3 or 4 days that requires opiates and hospitalization, and occurs again quickly as the patient goes home and stops taking their medication. And then finally, a very small percentage of patients become addicted to their pain medicines. They start abusing them. That population really has a great deal of difficulty because they have a chronic painful situation and also have a problem with the opiate medication. this is an uncommon problem, but really a difficult problem when it occurs. So in addition to the physical aspects of pain, there are really psychological and social aspects that have to be understood. Next slide. Now, the other aspect of this being a lifelong pain experience is that the individual with the disorder starts having pain in early childhood, and throughout their life, they have many interactions with healthcare professionals. And for the patient, this may be positive and rewarding, but it also can be negative. Very often, they'll run into confrontations with the healthcare professionals, and we all tend to remember negative occurrences more than positive ones. But the same thing happens to the healthcare professional. And so interactions with the patients and the family may be positive, but they also may be negative. And I think both groups tend to carry over these feelings to the next encounter. And so very often the patient, when they're presenting to the emergency room for healthcare, really has a high level of anxiety related to the fact that they don't know what kind of an experience this is going to be, whether it's going to be positive or negative. And very often the healthcare professional has the same concerns when they see a patient on the roster that they're going to have to see in the emergency room. And there is really a very important sociologic interactions that occurs, and really a negative perception of both groups of the other. And we have to understand this, and we have to start working to improve this, because it does have a negative impact on the individual. Next slide. And this really sort of summarizes that there are issues in sickle cell disease that are related to tissue damage, either directly from sickling or from remodeling of the nervous system, that induce pain. But we also have to understand that the cognitive and conceptual perception of this, the emotions and motivation around of the individual and their social and cultural experiences all impact on the pain experience. And as the patient ages, this becomes more and more an important aspect. Next slide. The other part of this, I think, is something we also have to understand about the dynamics of the sickle pain episodes in sickle cell disease. And this shows our emergency room data from 1988. And it's old data, but it's been reproduced in our center every year and in many other centers around the country that provide acute care. And basically, in the left in green are shown the number of patients, and on the right in red are the number of visits that are accounted for by those patients. And so we had approximately 40% of our patient population that had no visits for sickle cell disease that year. That is, they were none of them had a crisis that brought them to the emergency room. But we also had 28 patients that had over 2,700 visits. That is, they were coming to the emergency room greater than once a week, and they accounted for almost 60% of our visits. And if you look, the top 11% of the population accounted for over 80% of our emergency room visits. So in sickle cell adults, there are a very small number of patients who are having a very great deal of difficulty with their disease, and they're also the ones that are accounting for the majority of the health care interactions. And certainly this has impact on the cost of health care and utilization of health care. But I think more importantly, it causes a real problem in perception of what sickle cell disease is like. And an emergency room physician or an inpatient physician seeing sickle cell disease is only seeing this 11% of the population. And they have no concept that there are individuals with sickle cell disease who are asymptomatic and who are doing well with their disease and getting on with their lives. And so the healthcare profession really has a altered perception that impacts on the care of these patients. Next slide. And we looked at this and tried to characterize this, and when you look at this population of patients, it's a small number, and they have really immense problems. Many of them, or most of them, had problems in all dimensions. That is, they had significant medical problems. Their psychological functioning was poor. They had very poor adaptive skills. Many of them had frank psychiatric problems with depression, major depression, and actual psychoses. Social functioning was really very poor, with poor education, non-existent support systems, and really nothing in their life that they enjoyed doing, but really their life was totally focused around their pain and visiting the healthcare system. Next slide. The way we took this on was we organized a multidisciplinary pain team, and we developed care plans that would take care of the medical, psychological, and social issues. We needed physical and vocational rehabilitation to give the patient something meaningful in their life to do in addition to coming to the hospital for their pain. And then we certainly needed clinical pharmacologists to help us with pain management. And I must say that this is a very important component of adult health care, and it was also very difficult to maintain because of the financial considerations. Next slide. This type of intervention, however, is very, very cost effective, and this shows our center emergency visits before and after we initiated this kind of intense case management. And the 166 active patients that we applied this to, you can see there was a significant decrease in emergency room visits per patient year after implementation of the program in 1990. And so this kind of complex disease management is very cost effective. What I don't have data on is the fact that this really had a meaningful impact on the patients. And many of these individuals got married, developed social interactions, got jobs, finished their education, and we were really able to improve on their general quality of life in a very positive way. Next slide. I'd now like to just sort of highlight a couple of the medical considerations that I think are important that we need to think about in the adults. Again, there's very little data, but certainly the data that's in the literature is supported by our experience. I think the first thing we have to understand about the problem with pain is that there may be some things that we can do to improve this in a general way. And one of the first of these relates to vitamin D metabolism, and a study by Goldman in 2010 documented the fact that when they looked at 142 adults with sickle cell disease, virtually all of them were vitamin D deficient, and about 60% of this population had severe vitamin D deficiency. This has certainly been my experience in our center, and virtually every patient who we measured vitamin D on had deficiency. Not clear why this occurs. Part of it, I think, is because of the increased pigmentation, and about half of the vitamin D comes from sunlight. I think that the other problem with the sickle cell population is they probably do not get outdoors and participate in exercise and things where they would be exposed to sunlight. The vitamin D level was not related to age, sex, hydroxyurea use, or sickle type, and so this is sort of an independent risk factor. And then on the right side of the slide shows a study from St. Louis with, from Memphis, Dr. Adam Graves, and she looked at her males with vitamin D deficiency, and again found that about 40% of them had had osteopenia, and about 11 out of 78 had osteoporosis. And so on top of whatever damage the sickle is doing to the bones, they in addition have loss of calcium and bone loss related to the vitamin D deficiency. And this is certainly a correctable problem that hopefully will improve pain in these individuals in the future. We have preliminary data in pediatrics to suggest that the administration of vitamin D does really reduce the chronic pain that these individuals experience. Next slide. The other important problem that Dr. Sargent highlighted was the fact that the creatinines increased as the patients aged. We did a study looking at the prevalence of albuminuria in sickle cell disease in our center in collaboration with Dr. Gouache. And as you can see in the panel on the left, the individuals who have normal albumin excretion in the clear bars on the left decrease with age, and the numbers that have frank macroalbuminuria increase significantly as the patients get older. So basically 40% of the individuals over the age of 40 have macroalbuminuria, suggesting that they already have significant glomerular damage. We don't have prospective data yet to document whether or not this translates directly into renal insufficiency, but as is shown on the next slide, we have data from Los Angeles, the prospective data by Drs. Powers and Johnson, looking at their 25-year cohort of over 725 patients with SS and 209 with SC, that renal failure occurred in about 4% of the patients with SS and about 2.5% with SC. The median age of onset was young, at 23 for the SS and 49, 50 for the SC. And survival once renal insufficiency occurred was very poor in the sickle cell population, with a median age of death of 25, and the relative risk for mortality was significantly increased if they had renal disease compared to those who did not have any degree of renal insufficiency. So renal disease is common. We don't know how common it is. We don't know the natural history of its progression, but we do know that once frank renal failure occurs, that the prognosis is very poor. Next slide. Cardiopulmonary disease is also common, and the Boston individuals from Boston reported pulmonary function tests in adults with sickle cell disease, and they have probably a very highly selected population, but basically pulmonary function tests were normal only in 10% of the patients. And the adults really had a restrictive type of lung disease with restrictive physiology in 74%, with isolated decrease in DCO of 13%. So adults with sickle cell disease develop a chronic restrictive physiology, and this is associated with decreased oxygenation of the blood, which of course increases problems with sickle cell disease. And a Duke study from North Carolina looked at 43 deaths in their population, and about a quarter of them were related to cardiac causes, and 14% to pulmonary causes. Pulseless electrical arrest, pulmonary emboli, and acute multi-organ failure and stroke were the most frequent causes of death. And you can see that cardiopulmonary disease really contributed to this, with acute chest or pneumonia occurring in about 60%, pulmonary hypertension in 40%, and systemic hypertension in 25%. With heart failure in about a quarter of the patients. And so older patients with the sickle cell disease are clearly having cardiopulmonary problems. Next slide. A recent study from Baltimore suggests that also sickle cell is a hypercoagulable state, and that pulmonary embolization is also a problem, and about a quarter of the patients with sickle cell disease had evidence of pulmonary emboli. This was more common in patients with SC and S beta plus thalassemia, and it was associated with increased pulmonary hypertension. It had an independent relative risk of death of 3.6%, so certainly a very important problem occurring. So sickle cell disease, in addition to being a sickling phenomenon of blood cells, an inflammatory state, now also is clearly established as a hypercoagulable state, and this may become more important as the patients become older. Next slide. The genital urinary problems, certainly puberty is delayed in both males and females. Many of the females through their reproductive life have pain crises that are associated with each menstrual cycle. This isn't premenstrual syndrome. These are actual pain crises that are precipitated by the menstruation and by mechanisms that aren't clear. Certainly pregnancy can be problematic for the patients, and as my patient population aged, a large number of my older females started to have a lot of difficulty with pain crises in association with the hypermetabolic state that was associated with menopause. So they would get hot flashes and then go into pain crisis. In males, priapism and erectile dysfunction certainly are major problems as they get older. Next slide. There are neurocognitive impact. We showed with Dr. Kochi a long time ago that cerebral hemorrhagic events occurred with subarachnoid hemorrhage and hemorrhagic stroke, and clearly the SC patients and S beta plus thalassemia patients are having strokes at ages that appear to be younger than the general population. Elliot Vinchinsky clearly documented the fact that adults with sickle cell disease do not perform as well on general IQ performance tests, and this was correlated with both age and hemoglobin level, and he has suggested that perhaps transfusion and hydroxyurea will have roles in preventing this neurocognitive fall off. Next slide. All of the things that I've talked to you about really predate our use of hydroxyurea as a preventive agent. Next slide. Hydroxyurea clearly improves the symptoms in the patient population, and this is the original data from the MSH study where they documented that pain episodes are cut in half, the number of pain admits are cut in half, acute chest syndrome is reduced. The hemoglobin is increased, so transfusions are generally not as frequently given. And in addition, the patients have a higher mean hemoglobin, so they're less symptomatic from the anemia in their daily lives. Next slide. This has recently been documented in a number of different independent studies that suggest that survival is also improved with hydroxyurea. And one of the better studies actually comes from Greece, where they looked at a non-randomized comparative study where there were 131 patients treated with hydroxyurea and about 200 who did not receive hydroxyurea. Now, the reason this population is so important, or this study is so important, the patients were chosen for hydroxyurea therapy based on the MSH criteria of having greater than 3 pain episodes a year or 1 episode of acute chest in their lifetime. And so they actually were a more severely affected population than the control group. And despite this, they had a dramatically higher survival rate than the individuals with SS disease. And so basically 100% of the patients on hydroxyurea were alive were predicted to be alive after 10 years, whereas 10% of the control group were. For the S-beta 0 thalassemias, the numbers were 87% for the hydroxyurea group and 54% for the non-hydroxyurea group. And again, this is a highly statistically significant difference. They also presented data on S-beta plus thal that would suggest that they may have also benefited. However, the numbers were small and this was not statistically significant. There have been a number of other studies, the follow-up from the MSH studies and studies from France that suggest that survival is in fact improved with hydrea. And so hopefully the prognosis and for the adult will actually improve as we go forward. Next slide. The other thing that I think has to be kept in mind, and one of the reasons that I'm stressing primary care for the care of adults with sickle cell disease, is these patients now are living long enough so they have to deal with all of the diseases that are common to the general population. They're developing hypertension, diabetes, heart disease, cancer, rheumatoid arthritis, and many other diseases. And so in addition to the specialty care for their sickle cell disease, they need to have the same kinds of health care that the rest of us receive in terms of anticipatory preventive strategies. The other thing that we need much more data on is, what is the interaction with hypertension and diabetes on the heart disease and sickle cell, on the renal disease and the visual disease that can occur. And so we have to take care of these problems in the individual who has the disease, and we need to study the interaction between these common medical problems and the sickle cell disease. Next slide. This is my final slide, and it really is my conclusion, is that individuals with sickle disease are living longer. We don't have solid data for this, but there's certainly suggestion of it. Sickle geriatrics is real. There is a large cohort, or larger cohort of individuals who are older now, and we have to start thinking about dealing with the disease in them. Most of the patients with sickle cell disease live full and productive lives despite considerable challenges from their disease, and that always was something that these patients really inspired me over my years of caring for them, and how well they did, how productive they were despite this challenging disease. I think we also have to understand that many of them have long, almost normal, and very productive lives because they're virtually asymptomatic. And I think these individuals are missed in many of our surveillance activities, and that we need to include them in prospective data collection. And finally, that my bottom line is that we have almost no population-based data to support my conclusions or to understand the challenges that they may face, and that we really do need ongoing surveillance and a registry to collect prospective data. And I'm very excited about the project that you have in California, because I think this is really important. We need to define the disease, and as we go forward, document the impact of our interventions on the treatment of adults. So thank you. I will stop there, and hopefully we'll have some time for some questions.
So we have this line until 11:15. So if you have a question, please write it in the question box on your screen, and I'll read them out loud to Dr. Ekman. Thanks for that great presentation. The first question is, are there any new developments or medication besides hydroxyurea that can benefit adults who are intolerant to hydroxyurea?
Right now, the answer to that is no. And Dr. Houlihan pointed out that there are a number of activities that are in the pipeline for very promising drugs that are being studied now that hopefully in the near future will be available for the patients with the disease. But right now, hydroxyurea is the only approved drug that we have that has been shown to benefit the disease in terms of ameliorating complications. Transfusion therapy is really the only other active therapy we have, and certainly in selected patients that has a major benefit. But those are really the only two treatments that we have that are approved.
Okay, the same person put in a follow-up question. He feels that the side effects of hydroxyurea are not presented in the literature of caregivers prior to putting patients on the medication. Can you address that?
Well, I think that's a very important issue, and I think that that in general that might be at least partially right. I think a lot of hematologists have enthusiasm for the drug, and they want everybody that with sickle cell disease to be taking the drug, and so they do tend to minimize the side effects. And I have to add that the drug is incredibly well tolerated day to day, and most of my patients did not have significant side effects. The very predictable side effect is that it will lower blood counts, and so those have to be followed very carefully. And so when you're on hydroxyurea, you have to have frequent blood counts. There are other complications that are less complicated but need to be explained, less common but need to be explained, such as some individuals have an increase in their pigmentation when they're taking hydroxyurea. There are concerns about having children while an individual is taking hydroxyurea, and there are studies that suggest that the sperm count may be reduced in males while we're on hydroxyurea. However, this does not seem to last after they stop the drug. So the side effect profile of the drug is very good. We used the drug in the hydroxyurea study because we used it in other diseases for 20 or 30 years where individuals were taking it for that length of time and did not have significant problems. So it's very safe. Now, saying that, I do think that informed consent is really important when one is taking a drug like hydroxyurea. And so we would have a very significant conversation with an individual for an hour or so, explaining the benefits and the risks. We would send them home with a written summary of these, and then we'd have them come back at a second visit and answer their questions, and then see if they wanted to start the drug. Many of them chose to go on the drug, and a significant number chose not to go on the drug. And I think that process is very important. So I agree that it's very important that an individual understand both the benefits and the risks of any treatment that they're undertaking, so they have an opportunity to make an informed decision of whether they will take it or not. The survival data for me and some of the neurocognitive data that came out of the Baby Hug study make me feel personally that everybody who has sickle cell anemia should be on hydroxyurea, but I do present the positive and the negative and let them make the best informed decision that they can.
Thanks very much. We have another question. In your comprehensive care unit, what were the main non-medical treatments, such as psychological or social treatments, that you found had a positive impact on sickle cell patients?
Well, I guess a couple things. One of them was that the social milieu was very good, because all of the patients knew our staff, and all of our staff knew our patients. And because we took care of the individuals when they were in the emergency clinic, and we also took care of them when they were feeling well, we knew what they were like as when they're not in pain and when they're not miserable. And as we all know, when you have a bad headache or you have pain somewhere, your personality may change. And having that social interaction when an individual is feeling well was so important. But more important than that was that we had a nurse specialist in psychiatry who really worked hard with the patients to teach them, cognitive, behavioral techniques that would allow them to control their pain. We stressed things like hydration, good diet, and other things. And so there was, and then a very total care, because we knew the patients, we could identify medical complications quicker that were precipitating the crisis. And so very often health professionals and patients focus on the pain crisis as the important thing, but what's really going on is a urinary tract infection or some other medical complication, and once that's treated, the pain crisis abated. So we really used, I think, what would be called a holistic approach to the care, and I think that is extremely important.
Thanks very much. So there are some related questions about where did the funding come from for the 24-hour urgent care clinic, and using the clinic decreased emergency room visits, but probably created a lot more follow-up visits in the clinic. So how do you make the financial case that it's cost effective?
Well, we actually are. I mean, we were in the black. We did have a state grant that funded about a third of our operating budget. But despite the fact that we reduced the number of emergency room visits, the billing from the emergency clinic supported the health maintenance clinic. And actually, when the program was a combined pediatric and adult program, we were able to utilize the emergency room profit to support the pediatric social workers, some pediatric nurses, and other individuals. So it is a cost-effective model with one caveat. We have 1,000 active patients in our population and approximately 4,000 emergency room visits a year. And so you need a very large patient population for it to be cost effective. I think many of the treatment centers around the country are developing day clinics where they can incorporate a 12 or 8-hour emergency clinic into their general operating clinic, and that may be a more cost-effective model than ours unless you have an incredibly large population. But our program was cost neutral, and even without the state funding, we would have been able to maintain our follow-up clinics based on the income that came from the acute care.
Thanks very much. I think we have time for one more question. There's so many great questions here. Let's see. Can you comment on the mechanism of the decreased hemoglobin level you've observed in older adults with sickle cell? Have you primarily seen it in relation to renal function?
So the answer to that is no, and that was my hypothesis. But we had a large number of patients in our renal study that had renal insufficiency, and we had creatinines and erythropoietin levels, and we actually, the hypothesis was that as you got decreased renal function, you'd have decreased erythropoietin production, and the hemoglobin would go down. Now, we didn't see a good correlation with either the creatinine and the hemoglobin level or the erythropoietin and the hemoglobin level. So there's some other factor, and I don't know whether it's stem cell depletion or some other impact on the bone marrow that causes the progressive anemia, but at least in our series, it did not seem to be directly related to the renal insufficiency or secondary erythropoietin deficiency from the renal insufficiency.